She's from Sunnybrook and Women's College, Health Science Center in Toronto, Canada. Please, Jennifer.
Thank you, Mr. Chairman, and thank you to the organizing committee and Siemens for giving me the privilege to speak today about neural control of mechanical ventilation in infants. Neural control is presently an experimental mode of mechanical ventilation. It uses the electrical activity of the diaphragm to control both the timing and the level of the assist provided to the patient. It has the same goals as conventional mechanical ventilation, but it has the added aim of trying to overcome the problems that are associated with patient ventilator asynchrony. This is the most recent definition of asynchrony I could find. It states that it's a condition in which a mismatching between neural and mechanically assisted breaths occurs. Included in patient ventilator asynchrony, however, is something called flow asynchrony, in which the ventilator flow delivery is inadequate to match the patient's ventilatory demand despite a matched inspiratory time. And the point I want to make with this slide is not only is it important to time the assisted breaths with the patient's efforts, but also to respond to the changes in their demand. Patient ventilator asynchrony is complex, and there are a multitude of factors that contribute to it. Leaks in the ventilatory circuit, if there's any intrinsic PEEP, if there's respiratory muscle weakness, if there's any weird respiratory system mechanics, the algorithms of the ventilator, the reflexes, very strong in newborns and pediatric patients, the level of the assist, the trigger signal that you use, and like Mark was talking about, the cycling off criteria. Now, there are negative consequences of patient ventilator asynchrony, and if it gets so severe, we often have to resort to suppressing the respiratory drive of the patient, so we have to sedate them. And this has been shown more and more in the literature that you can get disuse atrophy of the respiratory muscles if you paralyze the patient. As well, it was shown that if you have poor cycling off, you can have pneumothorax and barotrauma. And we are strong believers that patient ventilator asynchrony is responsible for the failure to implement non-invasive ventilation. So I'd like to quote Dr. Greenoff in a recent systematic review on the topic, where she says that further trials are encouraged to assess whether modes likely to provoke synchronous ventilation will have benefits. So how do we improve the synchrony? Let's go back and look at our physiology. During spontaneous breathing, the desire to breathe originates in the respiratory centers of the central nervous system. The signals pass to the phrenic nerve, which electrically activates the diaphragm. After electrical activation of the diaphragm contracts. There's a generation of pleural pressure, the chest wall and the lungs expand, and there's generation of pressure, flow, and volume at the airway. Now, these pneumatic signals are the ones that are used to control the ventilator today, as the two previous speakers have pointed out. However, you can imagine with the disease process, the original signal will be transformed and dampened, and by the time it gets down here, will be very different from the original signal in the brain. So ideally, to have perfect synchrony, we would like to connect the brain directly to the ventilator, but this isn't possible. A phrenic nerve servo-controlled respirator was described in animals in 1976 by Remmers and Eunice, but it is not possible to measure phrenic nerve activity in humans today. The closest possible source to measure a signal closest to the respiratory centers is the electrical activity of the diaphragm, and this is the principle upon which neural control is based. This slide describes the setup that we use for neural control. We measure the electrical activity of the diaphragm with an array of electrodes that are mounted on a nasogastric tube. The tube is passed either through the mouth or the nose, down the esophagus, and positioned here at the level of the gastroesophageal junction, where we are recording the electrical activity from the crural part of the diaphragm. And here you can see an example of signals that we obtained. These signals are then fed to a PC. They're processed where we can monitor the electrical activity of the diaphragm, but also we can feed these signals to the ventilator for controlling the assist. This slide is just to show you a photograph of our esophageal catheter prototype that we're using at the moment. This is a polyurethane tubing. It's a feeding tube, so there's a feeding lumen inside here. And you can have any size you want. You can have 6 or 8 French. That's what we're using in the infants, and we go up to size 16 in the adults. On this polyurethane tubing, we've mounted wire electrodes. In the case of the babies, it's 7.5 millimeters between the wires, and we have an array of 8 sequential electrode pairs. And I just wanted to show you how small these electrodes are. They're approximately 0.1 millimeter in diameter, and they're actually embedded into the wall of the catheter so that you have no direct contact between the wire and the esophageal tissues, and therefore you can avoid damage. Now, neural-controlled mechanical ventilation is successful because of the signal processing. You can see it's not very pretty, the 8 signals that come out of our electrode array. You have contamination from the cardiogram here, as you see. Oh, by the way, this is one inspiration from FRC to TLC. You also have significant amount of motion artifacts that contaminate your signal. After we remove the ECG and the motion artifacts, the next step is trying to detect where the diaphragm is located along our 8 electrode pairs, because it can move downwards. As you breathe in, the diaphragm contracts and moves downwards along the electrode array. And we've developed algorithms that let us determine at any instant in the breath which is the closest electrode pair to the diaphragm. Then we can obtain our compound signal that we know has no artifacts and knows exactly where the diaphragm is. We can calculate the signal intensity and use a signal for neural control. Now, a lot of people say to me, why use this technology to measure diaphragm activation? Why don't you use surface EMG? Well, esophageal recordings of diaphragm electrical activity are not subject to contamination from other respiratory muscles. They are not affected by obesity. They are not affected by displacement of the diaphragm during mechanical ventilation or an inspiration, as I showed you in the previous slide. I spent 3 years of my PhD thesis proving that they're not artifactually influenced by lung volume. And in animals in 1967, it was shown that when you measure the diaphragm electrical activity with an esophageal electrode, it closely reflects the phrenic nerve activity. Now, how does the diaphragm activation respond to disease? We all know that as patients' respiratory muscles become weaker, the pneumatic signals that we're going to measure at the airway also become weaker. This is data obtained in a healthy subject breathing at rest, not on a ventilator, and breathing with a tidal volume of approximately 500 ml. He's using approximately 6 or 7% of his maximum diaphragm electrical activation to achieve this tidal volume. Now, if you look at patients who have diaphragm weakness, such as a COPD patient or a patient with prior polio infection, in order for these guys to achieve the same tidal volume, they require approximately a 4-fold increase in their diaphragm activation. And the point I wanted to make with this slide is that as your pneumatic signals get weaker and weaker, as your respiratory dysfunction gets worse, the diaphragm activation strength is actually going up. So for controlling a ventilator, from that point of view, it's beneficial. The electrical activity of the diaphragm has an advantage. Now I'm going to switch gears a little bit and talk to you about some of the modes of neural control. Neural triggering is simply providing an assist, such as a pressure support, in response to an early detection of the diaphragm electrical activity. These are tracings obtained in a COPD patient who is breathing on a conventional pressure support with an airway pressure trigger. Here we have flow, volume, esophageal pressure, and the ventilatory assist. What I wanted to point out here was that there's a significant delay between the onset of the diaphragm electrical activity by the solid vertical bar and the onset of the inspiratory flow, and this is probably due to the intrinsic PEEP that the patient had. Upon implementation of the neural trigger, however, we see that these delays are gone and that we have restored the synchrony. Okay, the patient had the same tidal volume, however, the esophageal pressure required was halved, indicating that there was a reduction in the work of breathing by half. And I guess I should conclude this slide by saying that neural triggering overcomes delays due to intrinsic PEEP. And I'm going to be a little bit bold here and say that, well, perhaps it wouldn't be necessary, therefore, to apply extrinsic PEEP for triggering purposes. I'm well aware of the importance of PEEP for recruitment of the lung. However, if you're applying extrinsic PEEP just for the purpose of improving the triggering with the neural trigger, you don't need to do that. I'm going to show you a slide now of my worst example of infant ventilator asynchrony. Here we have the diaphragm electrical activity and the airway pressure that we measured in a 9.5-month-old baby with aspiration pneumonia. And I just wanted to show you 3 examples of infant ventilator asynchrony. You have the delays between the onset of the diaphragm electrical activity and the onset of the assist. You see that there's a diaphragmatic effort during the delivery of the mandatory breath. And you also see the worst case of asynchrony, which is a wasted effort, where there was neural activation of the diaphragm, so the patient made an inspiratory effort from a neural point of view. However, the ventilator did not detect this. And this is just to show you an example over a 5-second period how conventional technology may sometimes be limited. Now, I mentioned at the very beginning of the talk that it's not just the timing that's important, but also the level of assist responding to the patient's demand. And that's where neurally adjusted ventilatory assist, or what we call Nava, comes in. Now, Nava is simply a mode of ventilation where the assist is applied directly in proportion to the diaphragm electrical activity. Here's an example of a healthy subject performing 1 inspiration on Nava. You have the electrical activity of the diaphragm and the airway pressure that I want you to pay attention to. And you see here that as his neural activation of the diaphragm is increasing and then going down after the inspiration, there was a perfect matching of the airway pressure in response to his activation. Now that's a single breath. What happens over several breaths when there's changes in drive? Again, this is the same healthy subject. This is the diaphragm electrical activity, and this is the airway pressure. Here you have the diaphragm activation during tidal breathing and the assist he was receiving from the ventilator. We then asked him to perform maximal inspiratory maneuvers, so the diaphragm activation increased for these 3 breaths, and the assist responded accordingly. We then asked him to perform a voluntary increase in his end expiratory lung volume, so he had to maintain a kind of a tonic activity of his diaphragm during expiration. So here's the diaphragm electrical activity, there's the tonic diaphragm activation that's maintained, and the phasic breathing on top. And again, the ventilator responded by providing a proportional assist, both in terms of the phasic and in terms of the tonic activity. And I could even maybe suggest to you that this is a neurally adjusted PEEP, and this is something we have to look at very carefully in the future. We all know that babies have very high breathing frequencies. Here's an example of the diaphragm electrical activity and the airway pressure in a 4-month-old baby breathing on an SIMV. We were just looking at how fast he was breathing and whether the diaphragm electrical activity could keep up with him, and yes, it did. This was a neural rate of 120. And we haven't used Nava in babies yet, but we have used them in rabbits. This is experimental tracings taken from a 2.4 kilo rabbit after an experimentally induced acute lung injury, and I just want you to pay attention to the assist delivered by the ventilator and the diaphragm electrical activity. Again, the rabbit is breathing on Nava, where the assist is directly proportional to the electrical activity. And what I wanted to emphasize here is that even with a neural respiratory rate of 156, we were able to provide assist in synchrony with the diaphragm electrical activity, both in terms of the timing, and we were able to respond to the drive as well. This is a slide to show you that Nava responds to the control of breathing reflexes. Again, we have data from a rabbit breathing on Nava, and what we've done is we've had the rabbit breathing on Nava at baseline levels, and then we've increased the gain factor by 2, 3, 4, 5, and 6. Let me remind you that this means that for a given electrical activation, the rabbit was receiving a proportional assist. Times 2 means that he was receiving twice the amount of assist for the given electrical activation. The gain factors were increased every 5 minutes. And I wanted to point out a few things. First, there was an increase in the assist because we are increasing the Nava gain level. The diaphragm electrical activity in response to the assist he was receiving became deactivated, so he was unloaded, and the diaphragm electrical activity decreased. There was very little change in the mean inspiratory flow. There was a slight increase in the respiratory rate. However, there was no change in the tidal volume, approximately 14 ml. Now, I have to remind you that this is not a physician that has prescribed a volume for this rabbit. This is spontaneously chosen by the animal. He can decide when it goes on and when it goes off. This corresponds approximately to 4.5 ml per kilo. So I would like to be a little bit provocative today and say that perhaps Nava might be a lung protective mode of ventilation. So I'm going to conclude by asking a question. What does Neuro-control have to offer? Well, it maintains patient ventilator synchrony. It responds to changes in respiratory drive. It's not affected by leaks, which opens up a possibility for new non-invasive devices. It responds to the control of breathing reflexes, which may be protective against lung injury. And due to the inherent nature of the technology, it maintains diaphragm activity during mechanical ventilation, and therefore we can expect to have less ventilator-induced atrophy. But of course, all this needs to be evaluated in the clinical setting. And I would just like to thank my contributors. Christer Sinderby, who is the inventor of the technology and the real motor behind the projects, Nora, my dedicated technician, the Swedish mathematicians and mathematical modeling and programmers, my clinical colleagues in Montreal I worked with for 3 years, and the people I'm starting to work with now in Toronto. Thank you very much, and thank you for your attention.